Hi, I am Chyrell-lyn. This video is made as a completion requirement for Module 6 Postgraduate Diploma in Diabetes for the University of South Wales. I am trying to simplify my approach in order for the non-medical listeners to also understand the context of my discussion. Let me start my discussion on the facts and figures presented by the World Health Organization regarding diabetes. There is a robust rise in the number of people with diabetes globally, from 108 million in the year 1980 to an uprise to 422 million in the year 2014, making diabetes is a worldwide epidemic. In simple statistics, there will be one diabetic in 11 normal persons. In 2012 to 2016, an estimated 3.7 million deaths were due to diabetes and its complications, such that in the same year, in 2016, the WHO has ranked diabetes as the 7th leading cause of death worldwide. Among the different types of diabetes, type 2 has largely taken its toll globally, for comprising 90% of the total cases, and type 1 takes the extra 10%. The increasing trend of its incidence is indicative that this will continue to surge to as much as 629 million in 2045, as estimated by the International Diabetes Federation. What is most depressing is that millions have been diagnosed globally, yet a lot of people are still suffering from being undiagnosed due to poor healthcare system or wrong social and cultural stigma of diabetes. It continues to be one of the most challenging diseases to treat since centuries ago. It has affected the healthcare system as an economic burden, especially in the middle to low-income countries, being the most with rocketing prevalence. 2 years ago, an estimated global healthcare spending costing $850 billion has been lost due to diabetes. What then are the risk factors in the development of diabetes? Unhealthy diet, overweight, physical inactivity, family history, increasing age, high blood pressure, hypercholesterolemia, impaired glucose tolerance, history of gestational diabetes, poor nutrition during pregnancy, and ethnicity. Diabetes is a disease that mainly involves the pancreas. After the food we take in is digested in the stomach, they are broken down into simple sugar called glucose that gets absorbed in the small intestine with the help of insulin released by the beta cells in the pancreas. Glucose are used in various cells in the body as a fuel for energy, and some are stored in the liver in the form of glycogen for future use. During fasting state or when blood glucose levels are low, the alpha cells in the pancreas releases glucagon and breaks down the stored glycogen back to glucose. This cycle creates a balance in the homeostasis of glucose levels. However, in diabetes, insulin levels are low even to the deficient levels, or insulin's action is ineffective, termed insulin resistance. An increase in glucagon secretion causes the rise in blood glucose levels. It is a silent but progressive disease that can be asymptomatic at its early course. Long-term uncontrolled blood sugar levels activate several deleterious biochemical reactions. These reactions are increased production of advanced glycation end products, activation of protein kinase C, stimulation of the polyol pathway, enhanced generation of reactive oxygen species, altered gene expression of growth factors and cytokines, platelet and macrophage activation, enhanced vascular inflammation. All this induces the formation of both micro and macrovascular complications, where microvascular complication targets the small blood vessels, leading to retinopathy and eye blindness, nephropathy to the extent of kidney failure, and neuropathy. While macrovascular complications damages the large blood vessels and collectively causes the so-called atherosclerotic cardiovascular disease, or ASCVD, involving the heart, brain, and peripheral circulation of the lower extremities. As per the American Heart Association, ASCVD is the most common cause of mortality in diabetics. Approximately 52% of type 2 and 44% in type 1 DM succumb to death due to cardiovascular disease such as heart attack, stroke, and peripheral arterial disease. As stated by the International Diabetes Federation, 9 in 1,000 diabetics dies due to stroke, while 7 in 1,000 dies due to coronary artery disease. On top of other comorbid conditions, a diabetic patient develops a variety of heart problems, such as atherosclerotic coronary artery disease, heart failure, diabetic cardiomyopathy, myocardial infarction, and arrhythmias. As per the Framingham study, the probability of dying from heart disease is 2 to 4 times higher in a diabetic patient as compared to non-diabetics. In one of the studies, they have cited that the 7-year risk to develop myocardial infarction in a diabetic patient is comparable to the risk of a non-diabetic who had previous heart attack. Therefore, diabetes is significantly considered as a CHD risk equivalent that would consequence to myocardial infarction. 70 to 80% of type 2 diabetes has lost their lives from cardiac mortality. The next most common and detrimental macrovascular complications of diabetes is cerebrovascular diseases. Diabetes mellitus is one of the most potent independent risk factors for the development of diabetic cerebrovascular disease or CVD. In fact, a diabetic with a pre-existing heart disease and atherosclerosis accelerates further the risk of developing stroke. The Interstroke Case Control Study, whose data are extracted from 22 countries, showed a 35% increase in the risk of developing stroke in diabetic patients. In a meta-analysis of Sarwar et al. In 2010 published in the Lancet publication, they concluded that there is 2.3 times higher risk of developing ischemic stroke and 1.6 times higher risk of having hemorrhagic stroke in diabetics as compared to non-diabetics. Unfortunately, once a diabetic stroke occurs, the outcome and disability is much worse and the tendency for recurrence is much more. Aside from stroke, diabetes has been a culprit in many of the brain diseases such as cerebral small artery disease, Alzheimer's disease, and dementia. PAD, or peripheral arterial disease, is also a macrovascular complication of long-standing uncontrolled hyperglycemia, which is characterized by an occlusion of any of the arterial branches of the lower extremities. When PAD is aggravated with neuropathy, atherosclerosis, and smoking, the higher is the likelihood of sustaining a diabetic foot disease, or DFD. DFD then is a debilitating consequence that initially starts with an ulceration of the foot, spread of infection in adjacent parts of the limb, or the entire limb that may either terminate to osteomyelitis or when atherosclerosis is severe, it potentiates development of critical limb ischemia. All of those pathologic processes would terminate to amputation. The International Diabetes Federation has declared that in every 30 seconds, lower limb or part of the lower limb is amputated due to diabetes. Following the declaration by the two large landmark studies in diabetes, which are the DCCT EDIC and the UK PDS trials, the tight glycemic control is valuable in the prevention of microvascular and macrovascular complications in diabetes. Their study on tight glycemic control also gave the term legacy effect and metabolic imprints, which means that an adequate glycemic control is commensurate to a sustained benefit with respect to long-term blood sugar control and metabolic advantage. Through the years, a lot of anti-diabetic medications has been formulated since 1920. Insulin compounds has been useful in treating type 1 and type 2 diabetes till today. And a much longer-acting insulin called degludec has been available. Different hypoglycemic agents has been formulated at any part of the defect in diabetes. Sensitizers such as biguanides and thiazolidinediones targets insulin resistance. While another type are the secretagogues such as sulfonylureas and meglitinides enhances insulin secretion by the pancreas. The newest generation of secretagogues are peptide analogs, especially GLP-1, which does not only augment insulin secretion, but an added feature of inducing significant weight loss makes it superior from the other secretagogues. Glycosurics are also one of the paradigm shift in the treatment of diabetes, as they inhibit the reuptake of glucose in the kidneys. SGLT2s has brought multiple beneficial claims in promoting weight loss, BP, and blood sugar control. In the new era of diabetes management, a pharmacologic challenge of producing a breakthrough medicine that does not just aim in glycemic control, but as well be able to treat the other comorbid conditions associated with diabetes risk, such as cardiovascular and renal complications. Doing the cardiovascular outcome trials is the new trend in comparing hypoglycemic agents, which were exemplified by GLP-1 and SGLT2 medications. I have come across a comprehensive summary by Heenan and Kruger published in Dove Press Online this year on the clinical impact of glucose-lowering medications based on their CVOT. And they have emphasized the following. Number 1, DPP-4s may not have the class effect on heart failure since linagliptin and sitagliptin do not increase the risk of heart failure in patients with diabetes. Therefore, it is unlikely that this medication will be given for cardioprotection. Number 2, for the SGLT2, the EMPERAG trial for empagliflozin and CANVAS trial for canagliflozin have proven favorable effect in improving MACE and cardiovascular outcomes, which made them superior in terms of cardioprotective benefits apart from the HbA1c lowering. While it has been postulated that the cardioprotective effects of SGLT2 may not be a class effect since the declared TIMI-58 study of dapagliflozin demonstrated non-inferiority but not superior for its endpoint on MACE, but rather a probable class effect in heart failure. Number 3, while for GLP-1, the CVOT leader for liraglutide has shown significant superior result that only a few subjects experienced MACE as compared to placebo. Number 4, in the insulin CVOT origin for Lantus 100 units had no significant difference on its effect to MACE, while DEVOTE trial of degludec has proven a non-inferiority versus insulin glargine in MACE. In the 2019 European Association for the Study of Diabetes and the American Diabetes Association, they have emphasized the use of GLP-1 and SGLT2, specifically liraglutide or semaglutide and empagliflozin respectively, to be the preferred medications when cardioprotection is needed by the patient, basing on the remarkable outcome of their trials. Overall, diabetes management must be targeted in treating and preventing both microvascular and macrovascular complications. The dictum of diabetes management are: number 1, adequate blood sugar levels by achieving the target goal of at least less than 7% HbA1c. Second, blood sugar control to less than 140/80 millimeters mercury is ideal. Number 3, cholesterol levels should be well controlled. Number 4, encourage smoking cessation. Number 5, all newly diagnosed patients must ideally be enrolled in diabetes structured programs for a collaborative and comprehensive management. Diabetes is a preventable disease, yet, till now, the advocacy of practicing a healthy lifestyle to seize its development is still a global issue. Let me quote one of the lines in the article of Hafner et al. In the New England Journal in 1998, that diabetes is one of the largest global health emergencies of the 21st century. It is disabling and can tragically take one's life if not properly treated. a threat that doesn't choose borders no matter if you're rich or poor. So a call to everyone in the healthcare industry to uphold a dedicated management to every diabetic patient by encouraging lifestyle change, early detection, and prompt treatment.